You can begin, Dr. Mehta.
Good evening and welcome to Spine Time, your free webinar where we discuss all things spine with our back and neck experts here at the Weill Cornell Medicine Center for Comprehensive Spine Care as part of New York Presbyterian Hospital. I have a really exciting topic today, but before we jump into that, let me give you some overview of what we're doing here. So as you know, Spine Time was started during the early days of the pandemic, where we engaged and discussed various topics on spine-related care with our patients and friends, and it's been going 2 years straight now. Our spine center is located on 59th Street and 2nd Avenue, and we have a complement of spinal surgeons, pain management doctors, and rehab medicine physicians. And then together we work with complementary medicine, mindfulness, CBT, and neurology physicians that are located throughout the Cornell and New York City areas. I am Neel Mehta. I'm one of the directors of the Spine Center and director of pain management. And today I'm joined by my two esteemed colleagues. First, Dr. Petrou, who's an instructor in anesthesiology and a pain management physician here in the Department of Anesthesiology at Weill Cornell Medicine. And also Dr. Lisa Witkin, who's the site director of pain medicine at Lower Manhattan Hospital in the New York-Presbyterian system, also an anesthesiologist and pain management specialist. Both of them have practices both at 59th Street and Lower Manhattan. And we're excited to talk to you about medication for back pain, whether it's something for a new episode of back pain or neck pain, or what happens when it lingers for a long period of time. Some housekeeping rules. We ask you to please silence any phones and computers that you have. And we also encourage you to engage with us on the chat. We'll be taking questions throughout the conversation. And if we don't get to you in your question, we certainly invite you to come make an appointment. Also, we may ask that you avoid very personal questions because it may not be something that we can answer directly. So more general questions are helpful. With that, let me turn it over to my colleagues, Dr. Petrou and Dr. Witkin. So welcome, thanks for joining us.
Good evening, everyone, and welcome. Thanks for joining us. So tonight's presentation is really going to be focused on pain medication for back and neck pain. But to start off, I just wanted to mention that pain management is more than pain medication by itself. And even looking just at pain medications, we have a lot of options besides opioid therapy, which is often a misconception or something that the public thinks is equivalent to pain management. So we often employ other types of therapies, including physical therapy and occupational therapy. There are a lot of other adjuvant pain medications that we offer with the attempt to try to treat patients using a multimodal treatment strategy. We often offer injections or targeted interventions to treat the underlying source of the pain generator. And then complementary and alternative therapies, things like acupuncture, massage, mindfulness-based stress reduction, and herbal supplements and things can be helpful as well. Next slide. So when focusing on the pharmacologic treatment for pain or pain medications, we often categorize pain medications into the following categories. So topical medications include things like over-the-counter medications, things like lidocaine and capsaicin, for example, are available over the counter, as well as in prescription strength in a patch formulation. And then sometimes we can prescribe a topical compounding cream, so we can mix a couple of different medications at a specialty pharmacy that can be very helpful. And topical medications are not absorbed very much throughout the body, so have minimal side effects, so can be very helpful for a lot of patients and well tolerated. Other options include acetaminophen or Tylenol, available over the counter, non-steroidal anti-inflammatory drugs, which are available over the counter, such as Advil, Aleve, ibuprofen, and also there are prescription strength NSAIDs as well. Steroids can be used to decrease inflammation. Antidepressants can be used to help manage pain, specifically tricyclic antidepressants and SNRIs, or serotonin norepinephrine reuptake inhibitors. Anticonvulsants, which are typically used to treat and manage seizures, but have been also shown to be very helpful in a lot of different pain conditions. Opioids, things like oxycodone, hydrocodone, et cetera. And then NMDA receptor antagonists, for example, something like ketamine can be very helpful. Next slide. So I'm going to talk a little bit further about a couple of these categories, starting with antidepressants. And so we know antidepressants can be very helpful for pain treatments, and the effects are really independent of their effects on mood. So often patients will say, well, I'm not depressed, why do I need an antidepressant? But it's really has a pain effect independent of the mood effects. Typically, tricyclic antidepressants were classically used or older medications that have a lot of evidence for efficacy. Examples of these include amitriptyline and nortriptyline. More recently, we've been using SNRIs, things like duloxetine, venlafaxine, and milnacipran are examples. And they tend to have better pain relieving effects compared to SSRIs, things like Paxil or Prozac, for example. Next slide.
Maybe we can pause for a moment here, because we've given a lot of really impactful things. And I know you're going to do a deeper dive into sort of the different medications, but if we go back here, and Dr. Petrou, feel free to chime in as well, where does one start? Like, what are you thinking in your head as a patient's coming to you for the first time as characteristics of pain and which classes of medications are better suited? How does the conversation go?
So I think often patients have tried over-the-counter pain medications before they come to see us. So often patients will try things like Tylenol or ibuprofen, Aleve, anti-inflammatory medications as first line on their own. I think the next steps of therapy are dependent on the underlying mechanism of the underlying pain generator. And that kind of guides us in terms of next steps. So if we think it's a nerve pain disorder, for example, then nerve pain medications can be very helpful. So the antidepressants or the anticonvulsants, which I'll talk more about.
And so maybe again, for our group, two things that I think about there. How does one know that they've given an adequate trial to an over-the-counter medication? What do you look for in terms of time and doses and frequency for a typical medication? And what's the better one of all the over-the-counter stuff?
So that's a good question. So generally these medications are taken as needed. The maximum dose that we typically recommend for Tylenol is no more than 3 to 4 grams a day. So 1,000 milligrams 3 to 4 times a day. So if that's not providing relief for patients, then I wouldn't recommend continuing it. And similarly for the anti-inflammatory medications, the NSAIDs, patients should notice significant improvement when using the medications. It's not really, a long-term effect that we're looking for. If they're not using it and getting some immediate benefit, then I would say it's time to move on to other treatment options.
So Dr. Petrou, how do you kind of counsel your patients on, first episode of back pain, maybe first episode of sciatica? What drugs are you thinking about and how do you guide them?
I agree with Dr. Witkin in terms of, by then for first presentation of sciatica, I do start with like the NSAIDs and the Tylenol. They probably already, by the time they see me, have also tried the patches like lidocaine patch. Often these are items that are already been prescribed or recommended by one's primary care physician. That being said, I do differentiate, I think as Dr. Witkin correctly pointed out, with patients who just say they have had no benefit, either taking Tylenol up to 3 to 4 grams a day, or they've have no benefit with the NSAIDs. And I agree with her in terms of, I don't want my patients on long-term NSAID use in which I worry about other long-term risks of something like GI upset. But that being said, for most, oftentimes I do patients at least have some mild benefit, especially something with Tylenol where I think it's safe. I will recommend that they continue it with it by the time they come into my care, with the idea that I am looking for a multimodal approach to pain management, where I'm trying to target the different pain receptors. So then, again, I think, when they first come and then presenting with sciatica and that they've tried these over-the-counter medications, basically by that point, it's time to go into the other medications that are really require prescription. And I think that dovetails nicely into Dr. Witkin's table form here, where we look into things like the antidepressants and the anticonvulsants, where now they're looking for basically a step up, which is not something that their primary care physician would have thought of immediately.
Got it. Okay, well, thank you for that. And I know we're getting some great questions coming in. In order to not jump around too much, I'm going to hold off on answering those, and we'll continue with our information here. So I know we got through this. Let's talk about some of the typical characteristics of pain that are well suited. So what certainly we have diagnoses here like neuropathic pain. How does one know that they have neuropathic pain?
So neuropathic pain, we classically think of pain that originates from some problem in the nervous system, either the brain, the spinal cord, or a peripheral nervous system, so kind of a pinched nerve, for example. Patients often describe this as burning and shooting in terms of the characteristic of the pain, and may also have numbness and tingling or weakness, depending on what type of nerve is affected. So those characteristics help us categorize the pain as neuropathic in nature.
And as we talk about these antidepressants, and I know you really hit home that it's not because we think somebody is depressed and so forth, but that we've had experience and research to show the benefit of these medications. What's the time frame to expect for one of these things to work?
So that's a good question. Unlike what we had discussed with Tylenol and anti-inflammatory, medications, these are not going to provide immediate benefit. So it can take several weeks, sometimes up to 4 to 6 weeks, to see the maximum benefit from some of these medications. And because of some of the side effects that are listed here, we typically start at a low dose and then gradually titrate or increase the dose to try to get the most effective pain relief. And so there may be a lag between when somebody starts taking this medication until we see the best pain relief from it.
Okay. Let's talk a little bit about anticonvulsants. I know this is probably one of the more commonly prescribed medication classes in our practice.
Right. So anticonvulsants are what we also consider as nerve pain medications. Initially, they were studied and used for the treatment and prevention of epilepsy or seizure disorders. So they tend to calm down irritated or excitable nerves. And in the same way, we know that all pain is sensed by nerves. And so it can help a variety of different types of pain states. So if you go to the next slide. Gabapentin and pregabalin are two very commonly prescribed nerve pain medications. And so they act by decreasing the release of an excitatory chemical that activates that activates the nerves, which is called glutamate. Both are similar in terms of this mechanism, but sometimes the side effect profile can be different for some patients. And Lyrica, we can titrate quicker to a therapeutic or effective dose. In other words, patients can start to see the pain relieving benefit sooner, often with pregabalin as opposed to gabapentin. Go ahead.
No, very powerful, and we have someone chimed in on the chat that gabapentin has been a lifesaver, so we're happy to hear that.
So they're very effective. They're very safe medications. Some of the side effects are listed here. So the side effects tend to be mild and they tend to be dose dependent. So as we slowly increase the dose, if patients are having side effects or problems, it tends to get better with time. If not, then we can lower the dose and the side effects should improve. So biggest side effects are somnolence. So it makes people sleepy, can make people dizzy or cause problems with vision or difficulty with concentration or attention. And less frequently, we can see things like edema or swelling, particularly of the legs, and weight gain, which typically is mild.
And, similar question as what we just talked about in the antidepressant class. Someone's asking, how quickly can it work?
Yeah, so some people notice benefit right away. I think some of it depends on the dose we use and the underlying condition. So there's some variability. But again, we typically start at a low dose to make sure patients can tolerate it and don't have side effects, and then gradually increase the dose until we see the response that we're looking for.
Great. One other question that came up, will you be able to get a copy of the presentation? So all of this is being recorded and will be available on our YouTube channel. And I'll show that at our last slide on how to access that. It's also available on our website for the Spine Center. So thank you for the questions so far. All right, let's keep going.
Great, and I think this slide goes back to what we were talking about earlier in terms of how do we know what type of pain we're having and what categories we're looking at. So what I talk to patients about is looking at either nociceptive pain versus neuropathic pain, as Dr. Witkin went into detail. So for nociceptive pain, I tell patients, it's what we're thinking about in terms of tissue damage. So a good example is post-operative pain, especially when patient has a procedures, there's been surgical stimulation. But that being said, more commonly, I also let patients know arthritis is something that we consider to have that be nociceptive. And again, that inflammatory keyword that Dr. Witkin had mentioned in her talk. Other sources or other conditions they put in the category of nociceptive pain include mechanical low back pain, which you very commonly see in our patients. And then looking if patients have any sport exercise injury, typically if they have like a lumbosacral sprain. Then separately, you look at neuropathic pain. You do see in this presentation, I'm very much providing a dichotomy. The reality is that these aren't completely mutually exclusive, and you actually oftentimes do have a mixed type. And that's why you will see that we'll provide certain agents for nociceptive that we commonly say are for nociceptive pain, but we also will treat for neuropathic pain and vice versa. Again, here I'm just kind of as an introduction, I just want to make sure that I'm able to properly delineate the two. So for a neuropathic pain, as Dr. Witkin had mentioned, is for our neuropathies, for our radiculopathies, lumbar radiculopathy, where we think there's irritation of the spinal nerve. When we go further in the periphery and we're looking at distal polyneuropathies, commonly we'll see it either like a peripheral diabetic neuropathy. And here we're looking at conditions where the primary lesion, where the pain is a source of the primary lesion or dysfunction of the nervous system. And then other conditions we'll see is like post-herpetic neuralgia, in the case of after shingles, or what another pain syndrome, we look at complex regional pain syndrome. And then here's with, in terms of, we talked about earlier, we mentioned how like NSAIDs are used for this nociceptive pain. Other things like corticosteroids can be used as anti-inflammatory.
All right. We've talked a little bit about corticosteroids or steroids in general, and I know, Lisa, you talked a little bit about the different ways that steroid can be used, both pill and injections. There was a few questions about steroids, so let's try to get back to those. One was on how long are steroids recommended for potentially a diabetic patient? So I'd assume that this is a question on not treating diabetics with steroid, but rather how safely can it be used, and what do you think about? And either one of you can take that.
So I think the important thing is in a patient who has known diabetes is that we coordinate with the primary care doctor or the endocrinologist. So we know that steroids can cause an increase in blood sugar or blood glucose levels temporarily. So we just want to make sure that patients are monitored, for example, after a steroid injection, or if they're taking steroids by mouth, and then their insulin levels or other medications are adjusted as needed. We typically use steroids in an injection or as part of an interventional therapy or a short dose of oral steroids. We don't typically prescribe high dose prolonged steroids for these types of painful conditions, because that can be associated with other side effects as well.
Sure. And how often is it safe to have steroid injections? And I know that's obviously for a variety of conditions, but how do you usually guide people?
I don't know, Philip, you want to?
Sorry, I'll jump in. Sorry.
You're right.
I don't want to leave everything for you. So typically I tell patients for a steroid injection, I wouldn't do more than 3 to 4 per year. I think as Dr. Witkin excellently pointed out, I am concerned about too much of a steroid load. You will see it's a little bit more nuanced in terms of an exact answer. As I do tell patients, if you have diabetes and you have you need a little bit more help in terms of managing your sugars and your A1C is elevated, I might be a little bit more conservative. But otherwise, for the typical patient, I'll say no more than 3 to 4 steroid injections per year.
Got it. There was a question, which I'll give to you, Phil, is what does CRPS stand for?
And I apologize for using abbreviations. So it's complex regional pain syndrome. There are 2 types, complex regional pain syndrome 1 and complex regional pain syndrome 2. CRPS 2 is a painful state of a nerve. So for example, you can have a posterior tibial nerve, CRPS 2, or you can have a sural neuropathy consistent with complex regional pain syndrome. The only reason I bring those 2 nerves out specifically is, for example, I had a patient today that I did peripheral nerve stimulation, which is a separate talk. And I know this is more focused on medications versus interventions, but that's what comes to mind. Versus for complex regional pain syndrome is when it is not a well-defined nerve that's involved. For example, the lower extremity or the upper extremity.
Right. Thank you. There was a question, which I think we've kind of answered in some fashion. Are steroids ever used to calm an existing inflammatory condition and then followed up with antidepressants for longer term use? And I'd say yes, that's part of our multimodal therapy that we've talked about here. Another question, there's a couple of things about muscle relaxants. How have you used them? Whether thoracic muscle pain or other back pains from muscle conditions. What have you found useful there?
Yeah, so muscle relaxants are another category of medications that we can use. They tend to be most effective in the acute period. So for short-term relief of back pain, often medications that are used as needed. Some of the side effects of those medications are, again, similar to gabapentin and Lyrica in terms of it can make people sleepy or dizzy. And there are a lot of different muscle relaxants out there. So if someone doesn't find relief with one of them, they may find relief or have a better side effect profile with a different muscle relaxant. So it's a bit of trial and error to find the right medication that works best. But if there's a component of muscular or myofascial pain, then yes, absolutely, it can be helpful as well.
I'm going to skip this one because this might get a little bit complex. But I know you, Phil, had put in this slide, which is near and dear to my heart too. Tell me about low-dose naltrexone and what you use it for.
Right, and I think the audience is very lucky to have one of the experts, Dr. Mehta. So anything I say that he disagrees with, I would say.
No, you're an expert too. So it's this healthy meeting of minds.
So for low-dose naltrexone, oftentimes first I just warn patients. You'll often hear it either in the news or historically you'll think of naltrexone as an opioid antagonist, and you'll see it labeled for patients who are either have a history of opioid dependence or a history of substance use disorder. And the reason I tell patients that in advance, because, you know, again, I think knowledge is power, and I know I want my patients to feel well informed and to be able to look up the information on their own. But that being said, I remind patients this is low dose naltrexone. So I'm looking at a dose much lower than the typical dosage used for those other conditions. So those other conditions are looking at 50 to 100 milligram dosing. I actually typically start at 4.5 milligrams. So again, I'm looking at much lower dosage. In terms of for medication, in terms of conditions that I'm looking to treat, you know, I look at our chronic pain conditions such as fibromyalgia, our complex regional pain syndrome, or chronic neuropathic pain. In terms of mechanism of action, so there are different mechanisms, but the one that I emphasize to patients is that it acts on the microglia, which I tell patients is the immune cells of the central nervous system, and that specifically it's an antagonist of one of those receptors. So it's essentially an anti-inflammatory agent. In terms of dosing, again, I will say every providers might have strong opinions about a range, and you'll typically see a starting dose of about 1 to 4.5 milligrams a day. Again, I start at 4.5 milligrams a day, and I dose it at night. Sorry, when I say day, but I do dose it at night. The reason I start at 4.5 was I had done my training prior to coming to Cornell. I'd done my training at Stanford in California, and they've done some excellent studies looking at low dose naltrexone. Specifically, they looked at a randomized, double-blind, placebo-controlled study for low dose naltrexone for fibromyalgia. I know that, you know, again, I think we want to be as how do I say? I don't want to use too many technical terms. The only reason I do emphasize it being as a randomized, double-blind, placebo-controlled trial is that it's almost a gold standard trial for when we look at medications. This was a small study, but again, having a pain study that's randomized, double-blind, placebo-controlled is pretty impressive. So there they looked at this 4.5 milligram dosing of low dose naltrexone for fibromyalgia. So that's where I carry over in terms of my practice. In terms of side effects, I do let patients know that it's one of our most well-tolerated medications. If they should experience something, typically it would be the vivid dreams. I talked about, again, that the dosing I do tell patients to take at bedtime. And then you see this target regimen, although again, each provider has some flexibility, and please don't be alarmed if you happen to be either on a lower dose or higher dose. But again, I aim for that 4.5 milligrams.
Great. There was a question earlier from Lori Gross about which one of these drugs doesn't cause weight gain that we've talked about throughout this evening. In my personal opinion and experience, this is one of them. It is a drug that generally does not cause sedation. It actually has been associated with improvement in energy, and it has been used in conjunction with another medication for weight loss, for prescription weight loss. So it is a very unique drug. We could talk for a whole hour just about LDN, which is what we call this for short. But I think you did a great job of just giving them a high level overview. I use it a lot in muscle pain and other types of neuropathic pain as well. This is great. Let's take some questions that have been coming in, and there's been some really great ones here. Medical marijuana, has it ever been used for chronic pain syndrome? Anybody want to take that one?
So yeah, medical marijuana can be helpful for a variety of different pain states. There's evidence that it can be helpful, particularly in neuropathic pain. There are other people who get relief from other chronic pain conditions with it as well. As you know, it's not FDA approved, and there's some legal issues surrounding it. It's still nationally considered an illicit substance, although you can get it with the prescription in the state of New York. So it potentially has some utility, although I think it warrants additional research. So hopefully that's coming in the near future.
And then what's the difference between medical marijuana and CBD in sort of a high level, one line statement?
Yeah, so I don't know, Phil, if you want to take this marijuana.
Yeah, so it's some of it has to do with the active ingredients in terms of the ratio of like the CBD versus THC. And I'm not an expert in it, and I agree. The reason I haven't become an expert because I agree with Dr. Witkin that some of the data was still waiting for it. But that's more or less my understanding, is that looking at for medical marijuana, it's including both versus CBD is just looking at CBD.
Yeah, so THC is the ingredient that's often associated with better absorption of CBD, which is the one that actually provides pain relief of medical marijuana. But THC has been associated with the euphoria and other complications with medical marijuana. And that's why we try to use as little THC as possible and more CBD. There are regulations about medical marijuana, so therefore there are some products out there that are over the counter that have no THC at all and CBD only. And there was a question about what form, so therefore you could talk about creams and edibles and oils and so forth. And the truth of the matter is that we don't know. It's very much anecdotal experience right now for that. We have a few more minutes. Somebody want to talk about meloxicam? What is it, perhaps?
So meloxicam is a prescription non-steroidal anti-inflammatory drug. It's often dosed once a day, so it's convenient for patients as opposed to ibuprofen, which you only last 4 to 6 hours, or Aleve or naproxen, which lasts 8 to 12 hours. Tends to be more COX-2 selective, which means it protects their stomach a little bit better. So in patients that have a lot of GI upset with other anti-inflammatory medications, they may tolerate that one a bit better.
Great. There was another question about Cymbalta. I think we talked about that before. It's one of the antidepressant classes and is a good choice. Obviously would have to be looked at specifically for you. There was a few questions, sort of not specific to medication, but sort of the philosophy of pain management and how we work with physical therapists, how we work with other doctors, how do we balance procedures versus medication. And I know that's a long-winded question there, but how do you guys think about this philosophy? Like, how do you talk to patients about the various things in multimodal treatment?
So I start the conversation with patients that I take a biopsychosocial approach to pain, meaning that everything is working together, and that one of the goals of my medications and one of the goals of my intervention is actually to help patients engage more in physical therapy. Oftentimes I'll have tell patients that I'll have patients say that, the physical therapy can be very uncomfortable, and that can often be a barrier to continuing physical therapy. So at that point, we'll have a conversation about medications that they're taking for their pain in order to engage and to be able to engage in physical therapy, especially the timing of the dosing and I remind patients that, to take some of the, especially the shorter acting medications that Dr. Witkin mentioned, take about like an hour, like thinking about my NSAIDs and my Tylenol, take an hour prior to physical therapy, or better yet, also for patients who are on those either the neuropathic medications, making sure that they're taking their morning dose before they go into physical therapy. And then again, I think similarly with the interventions, I tell patients that my goal is that once I've offered an intervention, we've successfully underwent it, that they should be able to engage more in physical therapy.
So I agree with all of that. And as mentioned earlier, we're part of a multidisciplinary spine center. So we work very closely with our colleagues in neurology and neurosurgery and physiatry, depending on what the individual patient needs and their response to different treatments that we offer.
Great. Well, I think that's a really great opportunity to close for the evening. We apologize in advance if we haven't been able to get to all your questions. I tried to group them together. Obviously, we welcome you to make an appointment, which the number is listed here. Visit our website as well. And as I mentioned before, we record these episodes and we do it just about every 2 weeks. So you can find our previous episodes on this website to be able to hear about some of the topics we've had before. In 2 weeks, I will be back as your host with 2 other colleagues of mine, and we'll be talking about spinal fractures and how that happens and the treatments that go on for that. As always, we thank you for your participation. This would be very dull and not enjoyable if we didn't have the interaction that you do. I want to thank my colleagues, Dr. Petrou and Dr. Witkin, who are really knowledgeable, and I hope you get to visit with them. And thank you to my hosts with the neurosurgery team that gets this up and running for us, Tatiana, Roseanne. I know I'm missing some other folks too. So as always, have a good evening, and we'll see you back in a couple of weeks.